Hello, my name is Florian Lordick from Leipzig, Germany. I want to give you an update about recent results presented at the ASCO, IGCC and ESMO GI meetings in 2019. These are the abstracts which I have selected, one reflecting new epidemiological data recently presented at ESMO GI. Then three abstracts about localized gastric cancer, two from the ASCO meeting, the ARTIST-2 and the PRODIGE 19 study, and one from the IGCC meeting, results from the CRITIC study. And last but not least, I will go to metastatic gastric cancer and the role of immune therapy, and I will present two ASCO abstracts, results from the Keynote 62 study and results from a phase 2 study performed at Memorial Sloan Kettering Cancer Center. So let's get started with some epidemiological data recently presented at the ESMO GI meeting. These were obtained at the INCAN Institute at Mexico City. The colleagues analyzed 2022 patients with gastric cancer seen at their institution between 2004 and 2016. 14%, 290, were 40 years old or younger. Interestingly, in this group of patients, there was a slight predominance of women. The mean age was 34 plus minus 4.9 years in both groups. And these younger patients have specific characteristics. The gastric cancer location is dominating over the esogastric junction location. They have more frequently gastric cancer according to the diffuse type, according to Lorentz classification, and all of them almost all of them had poorly differentiated histology. Most of them were diagnosed in the metastatic stage. Unfortunately, the majority of these patients have a very poor prognosis. Here the colleagues presented two Kaplan-Meier survival analyses which show that female patients with early onset gastric cancer have an even worse prognosis than male patients with early onset gastric cancer, but also males have a very critical prognosis. And on the right hand side one can see that in the metastatic stage the overall survival duration is really very short, with only 5 months median, but also in the localized stages 1, 2, 3, survival is very critical. So we can conclude that this early onset gastric cancer is associated with very poor prognostic features. So this is the conclusion from this presentation. Early onset gastric cancer, defined as age of diagnosis 40 years or younger, seems to increase in incidence in Latin America, maybe also in other parts of the world. More women are affected. This form of gastric cancer is associated with poor prognostic features like the discohesive type, diffuse type according to Lorentz classification, and presence of Signet ring cells, and it is associated with poor prognosis. So let us switch now to the topic of treatment of localized gastric cancer. I will show you some recent data. This slide here gives you an overview of different preferred treatment standards worldwide. As you know, in North America, some centers still prefer to go for resection first, followed by adjuvant chemoradiotherapy based on relatively old data of the SWOG intergroup study published in the beginning of the 2000s. In contrast, in Asia, the typical approach is primary resection followed by adjuvant chemotherapy, and in Europe and certainly also parts of America, including Latin America, the perioperative chemotherapy approach is preferred for localized and locally advanced resectable gastric cancer. Nevertheless, There is influence from the different regional treatment standards on other parts of the world, and Asian colleagues, especially the colleagues from Korea, have gained some data in the recent ARTIST-1 study where they observed that there is an indication that in patients resected who have nodal positivity, the addition of adjuvant radiotherapy to adjuvant chemotherapy may be associated with survival benefits. Based on that observation from ARTIST-1, the colleagues created the so-called ARTIST-2 study, where they wanted to validate and confirm the hypothesis that adjuvant chemoradiation is of benefit, of value in a population of gastric cancer patients with nodal positivity. So they intended to include in this ARTIST-2 study 900 patients with D2 resected gastric adenocarcinoma, pathological stages 2 and 3 with confirmed nodal positivity, stratified by stage, by type of surgery, and by Lauren classification. These patients were randomly allocated to receive one of the three treatments. One was adjuvant chemotherapy with S1 for 1 year. Second, in the yellow box, was adjuvant chemotherapy with S1 plus oxaliplatin for a duration of 6 months. And third, red box, was SOX chemotherapy plus radiotherapy. The primary endpoint was DFS, and the ultimate goal was to show that the addition of radiotherapy improves disease-free survival in patients with nodal positive resected gastric cancer. This plot here is already showing you the primary endpoint analysis, which shows that clearly the S1 group, the chemo monotherapy group, had the worst disease-free survival and was inferior to the two other treatment arms, but different from the study hypothesis, the addition of radiotherapy to SOX chemotherapy did not further improve disease-free survival. This can also be nicely seen in these two analyses. On the left-hand side, you see the comparison between adjuvant chemo monotherapy versus chemo doublet therapy with or without radiation, showing inferiority for the monotherapy and superiority for the combined chemotherapy, while on the right-hand side you see chemotherapy with or without radiotherapy, where no significant survival difference is shown. So it's easy to conclude from ARTIST-2 study that overall good survival results were obtained with an optimized surgical treatment, including a D2 lymphadenectomy. However, SOX, S1 and oxaliplatin was significantly better to S1 monotherapy even after good surgery, while additional radiotherapy, SOX-RT, was without an additional value. I think these are very important results because they show that after good surgery with D2 lymphadenectomy and an optimized adjuvant chemotherapy, the addition of radiotherapy is really not recommended. One word about signet ring cell cancer. You are aware, and I'm showing you here all the data, that there was always some doubt over the last years about the value of neoadjuvant chemotherapy in patients presenting with localized signet ring containing gastric cancer. This doubt was based on a retrospective analysis from a national French registry that indicated that maybe patients with signet ring cell cancer who receive neoadjuvant chemotherapy have even worse survival, a detrimental effect compared to patients who receive primary and upfront surgery. The French colleagues did something very good, which I will show you in the next slide. Based on this hypothesis, they created a prospective randomized controlled phase 2 study into which they included patients with stage 1B to 3 Signet ring cell gastric cancer. These patients were randomly allocated to receive either primary surgery followed by adjuvant chemotherapy with 6 cycles agrobicin, cisplatin and fluoropyrimidine. This was the control arm, or in the experimental arm, perioperative chemotherapy with 3 cycles ECF or ECX, followed by surgery, followed by 3 cycles ECF and ECX. And on the right-hand side of this, slide, I'm showing you one of the endpoint analysis these colleagues presented at the ASCO meeting, which shows that the perioperative chemotherapy approach was superior in this population. Patients who received perioperative chemotherapy had a higher R0 resection rate, and they also had improved disease-free survival rate in the intention to treat population and also in a modified intention to treat population. So the hypothesis could not be confirmed. It was not shown that perioperative chemotherapy is of any detrimental benefit. It was shown that perioperative chemotherapy is the recommended approach also for patients presenting with Signet ring cell cancer, as in other subtypes of gastric cancer. Then one word about microsatellite instability gastric cancer, which is one of the 4 TCGA-defined molecular subtypes of gastric cancer. It can be diagnosed by PCR or by immunohistochemistry, as you know. And we have seen some results over the last 2 or 3 years that patients with microsatellite instability localized gastric cancer, approximately 5 to 10% of the overall population that we see, may not gain any benefit from neoadjuvant chemotherapy or adjuvant chemotherapy. There was an interesting retrospective analysis on perioperative chemotherapy from the British MAGIC study, but there was also an interesting retrospective analysis from the Korean classic study about adjuvant chemotherapy, both studies indicating the lack of benefit from chemotherapy for MSI-high gastric cancer in localized stages. And this knowledge was now complemented at the International Gastric Cancer Conference by a first presentation and analysis from the CRITIC study, which also investigated perioperative chemotherapy with or without adjuvant radiotherapy. And in the first 21 patients which were analyzed, the investigators found 5.1% of patients with MSI-high gastric cancer. It is correct to say that 21 of 409 analyzed patients presented with MSI-high gastric cancer. This was associated with higher age and associated with intestinal subtype, things we already knew from the TCGA analysis. And interestingly, in their MSI population, they found little or no histological response to chemotherapy at all, no complete remission in their population, and not even any subtotal remission according to the regression grade by Mandar. So the hypothesis is confirmed, and it really seems that microsatellite instability localized gastric cancer is a poor candidate for receiving preoperative chemotherapy with a very low probability of response. So we definitely have to think about the best strategies for these MSI-high gastric cancers in the future, and there are some studies to be designed specifically for this subpopulation involving immunotherapy. So to summarize, that Signet ring cell cancer containing cancer patients should receive neoadjuvant chemotherapy according to the novel data presented at ASCO, while in MSI high gastric cancer there is more and more doubt about the benefit from chemotherapy in the neoadjuvant setting. So let me go now to the last topic, which is metastatic gastric cancer, and what you see here is the typically recommended treatment algorithm for first-line treatment and second-line treatment of advanced gastric cancer. You know that the assessment of the HER2 status by immunohistochemistry or by in situ hybridization plays a role to allocate patients to receive chemotherapy or chemotherapy and the anti-HER2 directed antibody trastuzumab. And the question now really is, does immunotherapy, PD-1, PD-L1 blockers play any role in the treatment of advanced gastric cancer? And now we have seen the first results about the potential role of the immune checkpoint inhibitor pembrolizumab, which is directed against PD-1 in the first-line setting of gastric cancer. I'm showing you here the results of the Keynote 62 study, which was presented at ASCO 2019. It included patients with locally advanced unresectable or metastatic gastric or EG junction adenocarcinoma, HER2 negative and positive for PD-L1 with a combined positive score of 1 or greater. These patients were randomly allocated to receive either, look at the green box, immunotherapy alone consisting of pembrolizumab 200 milligram per meter square every 3 weeks, or look at the orange box, pembrolizumab plus chemotherapy consisting of a standard regimen, cisplatin and 5-FU given every 3 weeks, or look to the red box, placebo and chemotherapy, which was the control arm. The primary endpoints were overall survival and progression-free survival, and with this slide here I'm showing you the relatively complicated construction, statistical construction and design of the study. What the Keynote 62 investigators wanted to show was either the comparison between immunotherapy alone and chemotherapy, or the comparison of immunotherapy plus chemotherapy and chemotherapy alone, and they wanted to show this either in a population with a CPS of 1 or greater, or in a population with a CPS of 10 and greater. This results in multiple primary endpoint analysis, which certainly has some advantages because you need to split the endpoint, which usually is set at a p of 0.05, which corresponds to 5%, and when you have to split it, you end up with much more ambitious and smaller p-values, which is part of the problem of the interpretation of the trial, which I will show you in the next slides. Here on this slide you can see the comparison between immunotherapy alone versus chemotherapy. The hypothesis here was that immunotherapy is non-inferior to chemotherapy, and we have to say that statistically this endpoint was met. But you see also, when you look at the Kaplan-Meier survival curves, that the curves are split in the beginning and that they are split at the end, but they are crossing, which means that at an earlier time point of observation, during the first month of treatment, the chemotherapy-treated patients had a better outcome, while at the longer time of follow-up, some immunotherapy-treated patients had a better outcome. This is a very problematic finding because it means, in simple words, that you harm some patients by giving them immunotherapy at the beginning to benefit some other patients by putting them on immunotherapy up front. And we really wish in such a situation that we have a better biomarker to distinguish these populations. And of course, attempts have been done to look if there are subgroups in the first plot, which you see on the left-hand side, that give an indication which group may benefit more or less from immunotherapy. It looks here that the Asian population with a CPS score of 1 or greater had a nicer benefit from immunotherapy versus chemotherapy, but this is of course a subgroup of a subgroup, and these are not very robust results. And when you look at the right-hand side of this slide, you see the analysis for a CPS of 10 or greater, which in principle shows still the same problem, that some patients have a detriment, a negative outcome with pembrolizumab, and some others have a positive outcome with pembrolizumab. So even with setting the threshold higher to a CPS of 10 or greater, you still have the same phenomenon that you do not know exactly which population will have a clear benefit from pembrolizumab. Very interesting findings, very difficult to carry these findings to a clinical setting. And the problem is really clear here when you look at the progression-free survival comparing pembrolizumab and chemotherapy. The majority of patients who receive pembrolizumab upfront experience a very rapid progression of the disease already during the first 2 months of treatment. Then let me come to the second comparison that was planned in this study. It's the comparison of pembrolizumab plus chemotherapy versus chemotherapy and placebo. The hypothesis here was that the combination of pembrolizumab and chemotherapy would lead to better survival outcomes, and this hypothesis was not met in the CPS 1 or greater population. You can see that the hazard ratio was only 0.85. The 95% confidence interval is 0.70 to 1.03, and the p-value with 0.046 did not achieve statistical significance according to the statistical considerations which I have shown you before. So this study result is clearly negative, and it is still negative when we change to the population characterized by a CPS of 10 or greater. Even in that population, the hypothesis that the combination of pembro and chemo is better than chemo alone was not met with a hazard ratio of 0.85 and a p-value of 0.158. So the conclusions here are that PD-L1 or PD-1 directed immune checkpoint inhibition alone and plus chemotherapy is not enough effective. We probably have a point with patient selection. We need better predictive biomarkers, potentially the analysis of DNA mismatch repair deficiency population, or a higher PDL threshold with a CPS of greater than 20 or 50, or the analysis of tumor mutational burden might be more informative. We are waiting for these post-hoc analysis to be presented, hopefully, at future meetings. Let me come now to the last topic which I want to discuss with you. This is a smaller study shown at the ASCO GI meeting and ASCO meeting 2019, presented by Jelena Janjigian, head of GI oncology at the Memorial Sloan Kettering Cancer Center. She did an investigation of patients presenting with stage 4 gastric and esophageal gastric cancer with HER2 positivity, which she exposed to an induction period of trastuzumab and pembrolizumab, so a combination of HER2-directed antibody treatment and PD-1-directed treatment. After this induction period of 1 cycle, patients maintained trastuzumab and pembrolizumab, but also received chemotherapy with capecitabine and oxaliplatin. This is still a very small study, but I'm showing you the major outcome results in the next slide. You can see here that within 32 patients exposed to this treatment, all patients obtained a reduction in the tumor size, and 87% obtained an overall response rate, 9% complete response, and 71% partial response. So this adds to a disease control rate of 100%. Very impressive results for a phase 2 study. And on the right hand side you can also see the promising PFS data and overall survival data. Of course, these results obtained in a limited patient population treated at one expert center need to be confirmed in larger populations. These studies are ongoing currently. The Keynote 811 study is comparing standard treatment with a combination of chemotherapy and trastuzumab and pembrolizumab, and we are eagerly waiting for these results. So this was my update from the 3 recent congresses. Very interesting results on gastric cancer research have been presented. IGCC in Prague, May 2019, ASCO held in June 2019 in Chicago, and ESMO GI held in July 2019 in Barcelona. I thank you very much for your kind attention.